The first thing I want to just stress is please don't let what I'm going to discuss today intimidate you from getting into treating Hep C, because most of the people you see are actually going to be the more straightforward ones that the type of presentations that Mia discussed in the last presentation. So here are my disclosures. I do some research with our VRCAN Viral Hepatitis Care Network that's supported by AbbVie and Gilead with investigator-initiated studies, and I do some consulting with them as well. So what I'm going to do is a quick recap, and I'm going to spend a little bit of time on the fibrosis assessment. So if you remember that this is really important, and very briefly go over treatment of non-cirrhotics, again, people without cirrhosis, and then we'll spend a fair bit more time talking about treatment with cirrhosis. The subtleties of treating HIV and hepatitis B co-infection, which fortunately are not very common. So we'll mention this, but don't feel like you need to have this mastered. It's not going to come up very often. And I will also stress, and again, that Mia, me, and others are available to try to help with any management of any cases. We're pretty good about getting back to people by email to go over individual cases. And we'll also remind you about our ECHO sessions that we run, which are funded by the Ministry of Health and our sort of telementoring program for managing liver disease more broadly, but we do cover hepatitis C within that. We're happy to try to help support people as you get started, because one of the things we've certainly experienced, and I experienced this with lots of other medical issues, is that it's sort of treating that first patient is always the most challenging. You're just writing that first prescription can feel a bit daunting. Once you've done this a few times, people become very comfortable with treating Hep C, and most people are get very good at it very quickly. But today we're going to sort of highlight when it can be a little more challenging and where you might want to ask for some help. And we'll finish with some case discussions. So a sort of checklist for thinking about how you choose a regimen and a few things to know. And the first thing we put on this list is the fibrosis assessment. So anyone, once you've made a diagnosis of Hep C, it really is important to figure out whether or not they have cirrhosis. And we're going to talk a fair bit about that today, why it's important. And I will say that as the drugs have become so much more effective and treatment has become so much easier, this is the one step that sometimes gets missed. People say like, oh, we can just treat them. We don't need to know about this, but I'll try to stress to you why it is still important to know this. Genotype, really, when do we need it? We don't need it as much as we used to. Certainly want to know about prior treatment history, and then some comorbidities, but these which are going to help guide treatment decisions around drug interactions and about ongoing risk exposures that people may have. So in terms of the fibrosis assessment, Mia talked about this last time, and it really is important that we don't miss cirrhosis. It may affect what regimen you need that you choose to use. It is definitely going to affect the need for post-cure hepatitis C care. So people that have cirrhosis, and I'll show you this later, really need to stay in care for follow-up for liver cancer surveillance. And so we don't want to miss this. And it's really nice if you have a FibroScan like I've shown in this picture. If you have it in your clinic, that's obviously nice to have. Most people don't have it in their clinic. It is important if you do have FibroScan days where pharma or someone else brings it into your community and they offer FibroScans. It's a really useful tool. You get the readout right away for whether someone's got significant fibrosis. But I would highlight that it's not a perfect test. And so if you think, someone's young and you don't think they've had Hep C for a long time, there's no other comorbidities, they're not using a lot of alcohol, so they're like a 28-year-old, the probability that person has cirrhosis is pretty low. So if you get a test result back that suggests it's really out of keeping with your pre-test suspicion, so you thought they didn't have cirrhosis and the test is saying they do, or vice versa, be a bit suspicious of the test. It's generally very good, but it is not perfect. And particularly if you get a high reading when you don't expect a high reading, some things to think about are whether there's a lot of inflammation in the liver. So if someone's liver enzymes are very elevated, the ALT is 700, don't use a FibroScan. It's going to be falsely elevated just from the inflammation rather than from scarring in the liver. And some other things, if the person's very obese, it can be challenging to get a good reading and it can raise the value a little bit. And even if they've just actually eaten a big meal just before it, the blood flow to the liver will make the readings a little bit higher and the liver a bit stiffer. So just be mindful of those things if you get a reading that you don't expect. But most of the time, rather than using the FibroScan, actually, we're going to use the simpler test, the APRI score, the AST to platelet ratio index, which Mia talked about last time, and the FIB4, because these can be done really by anybody. You just need a few simple blood tests. And the other nice thing is, if for whatever reason you chose to treat the person without getting a fibrosis assessment, you can often get these even after the fact. You can go back and get old blood tests through Connecting Ontario or something else and calculate this score to figure out whether they had cirrhosis before you started treatment. Importantly, these tests are not reliable after someone's cured. So if you've cured their Hep C or someone else treated their Hep C and you're trying to figure out whether they have cirrhosis or not, doing these tests after Hep C cure is reliably unreliable. So you can't really take the post SVR results as being reliable. And the reason for that is that the ALT and AST, which are part of these serum test panels, will normalize after someone's Hep C is treated. And even the FibroScan typically gets better in someone with cirrhosis, but it doesn't mean that all the fibrosis has gone away. It often means the inflammation, which is part of what's driving these tests, it has gone away. And all of the tests were only validated in people who had not yet been treated. So just be mindful of that.
So did you say it's okay to interrupt you and ask questions?
Yes, please.
Okay, so how old could the record results be that you would use to say if you had to go back into OLIS and decide somebody from that?
I think, I mean, anything is better than nothing. Fibrosis, liver scarring doesn't happen quickly. It happens over years. So even if you have something from 2 years before that was a very low score, the probability someone's progressed to cirrhosis over that time is very low. It's not zero, but it's very low.
Yeah.
I would say once you get much beyond 2, maybe like 3 years, now, of course, you're starting to worry that things may have happened over that time, but certainly you could use something going back in that time frame and be pretty confident. Again, because most of the time what you're going to be doing is ruling out cirrhosis, and this has very good negative predictive value. So if the score is low, you can be pretty confident they don't have cirrhosis. And I mentioned about the old records. If the score is high, the positive predictive value is not quite as good, so you may want to get another test to confirm it, especially like I mentioned, if you're not expecting them to have advanced fibrosis, and it suggests it does, and that's where FibroScan may be helpful if you have access to it. One thing I really want to stress is that ultrasound is not a good test for cirrhosis. People often use this test for cirrhosis. It's not a good test for cirrhosis. It's very insensitive, meaning that often people with cirrhosis will still have a pretty normal looking ultrasound. And so there's two sort of points about the ultrasound, and I'll mention this again later, is that the ultrasound is important in someone with cirrhosis to make sure that they don't have a liver cancer before you start treatment. But whether or not they have cirrhosis really can't be determined very well from ultrasound. And this can be important because sometimes people may not have access to ultrasound. So there's sort of this tendency to want to get it in everybody. Sure, it's nice to have, but if you think based on your serum tests or a FibroScan, if you have it, that they don't have cirrhosis, you can skip the ultrasound step, and that can expedite getting people on treatment and save them time. So this is just to remind you what those tests are, the FIB4 and the APRI score. And so FIB4 slightly preferable. It's a little bit more reliable test. And so these are on MD Calc, so you don't need to calculate these yourself. But the one important thing is you do need the AST in addition to the ALT. And just to remind you that this is covered in Ontario, you just have to write insured on the requisition and you can get the AST done. And then you also need a platelet count and the age. And the test is supposed to be done for people under the age of 35, between the ages of 35 and 65. So not under the age of 35 or over the age of 65. If you have younger people, usually what I do is just the age will always raise the score. So a conservative approach is if you have a 28-year-old and you put in for their age, just putting it in as 35. If it's still giving you a low reading, you can be comfortable that they don't have cirrhosis. It's pretty uncommon for people under 35 to have cirrhosis from Hep C. It's not impossible, but it's pretty uncommon. And similarly, if in older people, I'm usually pretty comfortable using it in older people, but just be mindful that if you put an age of 75 in, it's going to give you a high score. So you may want to lower it back down to 65 so you're not coming to the conclusion that every old person has cirrhosis, which fortunately they don't.
So you wouldn't just use APRI outside of that age range?
I mean, you certainly can. I just would say the APRI is a little bit less reliable. So, I mean, you're just getting a bit more information with the AST and ALT with the FIB4, because it's in addition to the AST, it's giving you the ratio between the AST and ALT. And then if you have the FibroScan, that's great. If you can get access to it. The other thing that if you never have access to FibroScan, another test you can do is something called the Fibro test, where you have to send off a panel of blood tests. If people want to ask me about that, just let me know and I can go into more detail. I don't have any specific slides on it. So if you come to the conclusion that cirrhosis is present, and now I'm going to spend a bit of time talking about cirrhosis, this is when the first and most important thing you need to clarify is whether the person has current or past evidence of liver decompensation. And I'll talk a little bit more about what I mean by that. But really, this is showing signs where the liver is not working. And the reason that that's true is that people who have had or have current evidence of hepatic decompensation, they cannot take protease inhibitors. So if you remember, one of the choices of regimens, the pangenotypic regimens, is glecaprevir, pibrentasvir, or Mavorite, and that contains a protease inhibitor, and those are not to be used in people where the liver is not working well because they're completely metabolized or broken down in the liver. So that's probably the most important reason we need to know about this. It also affects their safety. I mean, I would say unless you're very comfortable treating Hep C and managing advanced liver disease, this is a group of people, if they do have past or current decompensation, who you should be thinking about referring. And so the question is, how do you recognize this? Well, there are some simple scores. They're not that simple. I'm going to show you an easier one, but this is a score called the Child-Pugh score, which has been around for a long time, and you get 1 point for each of these things. And there's an online calculator. You don't need to remember the thresholds for these, but it takes into account 3 blood tests, the bilirubin, albumin, and INR, which tell us about how the liver is functioning, and then the presence of ascites or fluid in the abdomen and hepatic encephalopathy. And you get 1 point for each of these if everything is normal. So the minimum score you can have is 5. If the score is above 5, so if any of these are abnormal, meeting the thresholds that you would calculate on, again, MD Calc, you should be careful. These are patients that have more advanced liver disease and may get into trouble with Hep C treatment. Fortunately, that's going to be the minority. Most people don't have cirrhosis, and those that do have cirrhosis will usually have compensated cirrhosis. An alternative to the Child-Pugh score is something called the MELD score, or Model for End-Stage Liver Disease, and it takes into account these three lab tests, bilirubin, INR, and creatinine. And again, if it's high, you should pay attention. There are online calculators, and I'll show you the calculation in a second. And the reason for this is, as I mentioned, that the FDA, when the drugs came out, put out actually a black box warning for Mavorite, this is the American spelling of it, and Zepotir and Vosevi. All of these regimens contain a protease inhibitor, and that they were concerned that when you give these to people with more advanced with more advanced cirrhosis, that they can get into trouble. And they actually did have some patients that had progressive liver decompensation and even a few deaths. And this typically happened in people with Child-Pugh B or C cirrhosis, so really more advanced cirrhosis. But even in Child-Pugh A, so the lowest grade of cirrhosis, I'll show you what I mean by this in a minute. But remember, I said the lowest score you can have is 5, even just being 1 above that. So a Child-Pugh score of 6 put people into a higher risk. And so this is a group where if you do choose to treat them, they shouldn't get a protease inhibitor, but you've also got to be careful. If their bilirubin is going up on treatment, you need to stop treatment, because the drugs can occasionally be liver toxic. And the reason we really want to know about cirrhosis is it's only once people have cirrhosis that they're at risk for all of these complications of variceal bleeding, developing jaundice, becoming confused, or hepatic encephalopathy, ascites, or developing liver cancer. And fortunately, even if someone's got compensated cirrhosis, we can generally prevent these from occurring. So it really is important to distinguish between this concept of compensated and decompensated cirrhosis. Compensated basically means the liver is damaged, but it's still working fine. It's doing all the jobs in the body that it needs to do, but it is quite scarred. The challenge with compensated cirrhosis is that the diagnosis can be pretty subtle, because people may have few or no symptoms. They might be a little tired, but often don't have any other symptoms. They may have all of these things that we learned in our training about signs of chronic liver disease on physical exam, but the reality is most people have none of these findings. So someone can have cirrhosis in your clinical exam and their symptoms, they have no symptoms and their clinical exam's totally normal. And actually their liver blood test may be pretty normal. So the only thing that you may notice is that the platelet count is low and that the AST is greater than the ALT, which is usually the opposite pattern of what we see in chronic hep C. So you can imagine that someone could walk into your clinic feeling and looking pretty perfectly fine with cirrhosis, and that's why this is easy to miss. If they have decompensated cirrhosis, diagnosis is usually pretty obvious. If someone's got a big swollen belly with ascites, they're bright yellow, they're very confused, it's usually pretty easy to pick this up, and they've already got abnormal liver function. But here, obviously, they're sicker. It's important to remember it's not just current, but it's also past decompensation, which is a big risk. So you want to ask about these things in someone where you've identified that they have cirrhosis. Have they ever had ascites? Have they ever had a variceal bleed, confusion, etc.? And then, so what I mentioned before is that Child-Pugh score, and here are just actually the values. So I mentioned it includes the 3 blood test values, as well as the presence of ascites and encephalopathy, and then you get 1 point of everything is normal. So if these values, the blood test values, are below these thresholds and you don't have ascites or encephalopathy, you should only calculate this in someone with cirrhosis. So if they don't have cirrhosis, forget about the Child-Pugh score altogether. And then you get extra points if the INR or bilirubin are elevated, or the albumin is low, or they have ascites or encephalopathy, and can get up to 3 points for each of these things. And so then they categorize the child score into 3 major categories, A, B, and C. A is the least severe. So again, a 5 is complete, everything is totally normal. A 6 would mean one of these 5 things meets the threshold for a score of 2. And the reason that these are categorized this way is if someone has Child-Pugh A cirrhosis, you can see that their long-term survival is pretty good. It may even be significantly longer than this if you can cure their hep C. Whereas once you get into decompensated cirrhosis, which is anyone with Child B, so a score of 7 or higher, you can see that their survival is dropping significantly, and if they needed surgery, a very high risk of surgical mortality. And if they get into the category of Child-Pugh C, this is really sick. These are people who need a liver transplant, and you can see that their median survival, only half of them will be alive 2 years after. 2 years later. So this is a really sick group, and you can see this graphically just showing you here that in this group of Child-Pugh C, they have very poor survival, whereas Child-Pugh A does quite well in the short and medium term. And that MELD score I mentioned before, again, it includes these 3 blood tests, so it's very objective. You don't have to decide if they have ascites or encephalopathy. Not easy to do in your head. It's a very complicated formula. It does correlate well with their mortality risk, and so this is an alternative to use, and either score is fine to use. If someone does have decompensation, there's sort of 2 major ways this happens. The first is that they can develop consequences of what's called portal hypertension, where the pressure is high in the blood vessels going into the liver. And this can, when the pressure is high, that can lead to the development of ascites or fluid in the abdomen, of esophageal varices, so swollen veins in the esophagus that can rupture and bleed, hepatic encephalopathy, or these rarer complications. And the other side of it is, in addition to the pressure side, is actually the liver not working. So not making the factors, the proteins that the body needs, so albumin, the blood clotting factors, and also metabolizing things, so bilirubin or any medicines that we give people. And the relevance to hep C is really that if there are any signs of decompensation, I keep stressing this, past or present, these are probably people you want to refer unless you're very comfortable treating, you've treated a lot of hep C. But the other reason you want to know about, you also want to know about cirrhosis is that after treatment is that they need to have cancer surveillance, even if their FibroScan and or their blood tests all get better. So I mentioned about the ultrasound not being very good for ruling out cirrhosis, and this is just to highlight this point again. So this is going from a normal looking liver here to a very scarred looking liver here. And the truth is that up to this stage, so these earlier stages of scarring, look completely normal on an ultrasound. And even someone with cirrhosis, the liver may look normal on ultrasound. So some things you can use that can be a little helpful is if the liver, if you do see a big spleen, or a very nodular, obviously nodular liver, those are pretty specific findings. So if they're present, they probably do have cirrhosis, but if they're not present, you cannot be confident that they don't have cirrhosis. And then you really want to use this more to look for HCC in someone with cirrhosis, is to make sure that they don't have hepatocellular carcinoma or liver cancer before you go on to treat them. So if they do have cirrhosis, you want to do an ultrasound, but don't use the ultrasound to rule in or rule out cirrhosis. If you do actually find someone has a mass, so they have cirrhosis, and you go on and you do your ultrasound, if they do have a mass on the ultrasound, it's useful to order an alpha-fetoprotein. This is a tumor marker. If it's high, particularly above 20, then you should have a high clinical suspicion that that mass may indeed be cancer. But this is not a perfect test. It's not perfectly sensitive. Some tumors don't make it, and it's also not perfectly specific. Some people with very active hepatitis may have a slightly elevated alpha-fetoprotein as well. And then they would need additional imaging to sort of confirm the diagnosis. We don't usually need to biopsy liver cancer. We can make the diagnosis with CAT scans or MRIs, but you're probably also going to want to refer these folks up. So I'm not trying to scare you about cirrhosis, because the truth is that yes, we can indeed treat most people with cirrhosis. It just really does affect the urgency of treatment, their prognosis, a little bit the treatment response, but not that much. May affect the treatment regimen if they have decompensated disease on treatment and post-treatment follow-up. So if you suspect cirrhosis, fibrosis assessment, if they have signs of decompensation, refer. If they have no signs of decompensation, then getting a FibroScan is still useful. So if you get a FIB4 score that's very high and you think they probably have cirrhosis, the benefit of having a FibroScan, if it's available to you, is that it can help you decide whether someone's likely to have varices. If the FibroScan is above 20, then they have a pretty high likelihood of having varices and should go on to get a gastroscopy done before starting treatment. Whereas if their FibroScan is low and they don't have any other signs of decompensation, this is someone you could be pretty confident that you could go ahead and treat without having to worry about these extra steps of getting endoscopy. So it's still useful if it's available. Of course, it's not available in all places. Now, one other way to try to figure out if someone's got decompensated cirrhosis, this is a complicated slide, but the highlight is here, over here on the left, that if you're trying to figure out whether someone has decompensated cirrhosis, we did this a couple of years ago where we sort of looked at some simpler tools to figure that out rather than those complicated scores. And what we found is that if you want to use a pretty simple rule to say it's safe to use a protease inhibitor and to go ahead and treat this person, if their albumin is 38 or above, so that's almost a normal albumin, and their platelets are above 130, you can see that in pretty large cohorts, over 2,000 people, we saw nobody got into trouble if they met both of these criteria in people without cirrhosis, and even in people with cirrhosis, over 200 people without any problem. And even if you took a prior history of decompensation, which is a group who probably shouldn't get a protease inhibitor, but still there, the risk was pretty low. So this is a pretty useful, simple rule. It's probably conservative. You could go lower to a lower albumin and platelets and still treat people. But if you want to be conservative and sort of safe, you can use these as a guiding principle that if the albumin is preserved and the platelets are above 130, you should be good to go with any of the current regimens. Now, I'm going to just, I know I've stressed this a lot, but I'm going to stress it one more time. If you do have someone who's decompensated, these patients really can get sick on treatment at any time. So you've really got to be careful. And I would say that in general, these are people that you're better just to refer at the very minimum to be doing this as co-treatment, where someone with a lot of experience treating Hep C is managing this with you through email or some other approach. So in people who have compensated cirrhosis, which if you see it is likely who you're going to see, then fortunately the treatment actually is not much different than in people without cirrhosis. So if you remember from what Mia talked about last time, in people where you don't think they have cirrhosis, then for all the genotypes, you can either use glecaprevir probenesphere or Mavorite for 8 weeks, or you can use sofosbuvir velpatasvir or Epclusa for 12 weeks. And doesn't really matter, at least from a liver standpoint, which of these two regimens you use. Now, if they have compensated cirrhosis and you're comfortable using a protease inhibitor, using that rule I just showed of an albumin above equal to or greater than 38 and platelets above 130, then you can use glecaprevir probenesphere for 8 weeks. Or you can use Sofvel for 12 weeks in everybody except you'll see that there's one genotype missing here, genotype 3. And this is going to be one point it's a subtlety, but it's an important subtlety because genotype 3 is the most common genotype among people who acquire hepatitis C through injection drug use. So genotype 1 and 3 are the most common genotypes altogether, but 3 is much more common among people who inject drugs, which is how many people acquire hep C. So I'm going to share this. I'm just going to go through this in a little more detail and just remembering that the treatments are generally pretty well tolerated. And if they don't respond to a first-line regimen, then this is our second-line regimen. It's called Vosevi is the trade name, but sofosbuvir, velpatasvir, voxilaprevir, a bit of a tongue twister, is the sort of salvage regimen. But so why do we sort of highlight genotype 3? Well, so these are the data using Epclusa or sofosbuvir velpatasvir, and you can see that in everyone with genotypes 1, 2, 4, 5, and 6, whether or not they've been treated before, whether or not they have cirrhosis, the cure rates are almost perfect. Can't get much better than 99%. And even in people with genotype 3, and sorry, this is actually just people getting sofosbuvir velpatasvir, so Epclusa, sorry, there's an error on the slide. And you can see comparing people without cirrhosis, so F0 to F3, or people with cirrhosis. With cirrhosis, still pretty good results, above a 90%, but it's not getting above that magical number of 95% that you do get with people without cirrhosis. So this is what led to this question could we actually get above the 95%? And so there was this study done where they took people and gave them sofosbuvir velpatasvir, so Epclusa alone, or Epclusa with ribavirin, and for 12 weeks again. And what they found is that if you added ribavirin, you got the SVR rate, the cure rate above 95%, that magic number, got it up to 96%. But then they broke it down, and what it turned out is that even though these people had never been treated before, a proportion of them, about 20% of people, will have resistance to the velpatasvir part of this combination, even though they've never had treatment. And this is really what affects the response. So you can see in the people who had resistance, that's what this RAS means, resistance associated substitution. You can see that if they got Epclusa alone, the SVR rate dropped down into the 80% range, whereas if they added ribavirin, this overcame the resistance. You can see everybody but one ended up being cured, and the SVR rate gets above 95%. So I'm spending a bit of time on this as it's sort of a subtle point. This is just in genotype 3 cirrhosis. If you wanted to use sofosbuvir velpatasvir, Epclusa, is that then you need to think about using ribavirin. Now, some people say, well, what's the big deal? You can just retreat them if it doesn't work the first time. Well, the one thing that predicts not responding to this salvage regimen, a sofosbuvir velpatasvir, voxilaprevir, or Vosevi, is having previous sofosbuvir velpatasvir. And it kind of makes sense. You can see that these are 2 of the 3 drugs that are used in this triple combination. So that's why the SVR rates, they're not terrible with retreatment, still in the 80%, but not in the 90+% that we typically see with retreatment. And we did a study looking at this in Canada and found the same thing, that the only predictor of not responding to retreatment was having prior sofosbuvir velpatasvir. So you kind of want to get it right the first time, and that's why this sort of subtlety of genotype 3 and cirrhosis is relevant. And so just to make the point that you do have an alternative here, and if they can take glecaprevir probenesphere or Mavorite, So you can see in people without cirrhosis, cure rate's very, very high, 99% overall. And these numbers where they drop down to around 90, that's just a very small number of people treated because it's a rarer genotype, but this works across all the genotypes, including genotype 3. Here you can see 95% there. And even in people with cirrhosis getting this combination, even in people with genotype 3, you can see that if you look at people failing because the drugs don't work, you can see only 1 out of 61 didn't respond. A couple of people were lost to follow-up using the so-called intention to treat approach. So so I showed you sort of the background data, but let's just bring it back and say, what does this mean practically speaking? So you have a simple paradigm. You're going to do a fibrosis assessment in everybody and the pre-treatment labs. If they don't have cirrhosis, you can use either of these regimens, glecaprevir, probenecvir, or Mavorite for 8 weeks, or sofosbuvir, velpatasvir, or Epclusa for 12 weeks. And you're just going to really help you decide based on what the patient prefers or drug interactions. If they do have cirrhosis, then your first question is, can they take glecaprevir, probenecvir? Because if they can take this, you don't need to think about that question about genotype 3 and cirrhosis. I showed you that this works across all the genotypes in people with compensated cirrhosis. So the question you need to ask here is, yes, they have cirrhosis. Can they take this? Well, to take this, they can't have a history or current decompensation, and there can't be any significant drug interactions. If the answer to this question is yes, they're eligible, then you can just go ahead and give them 8 weeks of Mavorite and you're good to go. But if they can't take this, now you're stuck where you've got to go and use sofosbuvir or velpatasvir, and now you really want to know if they have genotype 3. If they have any other genotype, go ahead and treat. There's no real problem. But if they happen to have genotype 3, then either you want to do that resistance testing to find out if they're the 20% who already have resistance and need ribavirin, or just give them ribavirin up front, which I would say generally I don't do because it's not the best tolerated drug, and now it's become a bit harder to access it in Canada. So if we sort of go back to a simplified approach, you assume that we're going to assume that you refer anybody that's got a history of or current decompensated cirrhosis. If they have genotypes 1, 2, 3, 4, 5, or 6, so any genotypes, you can use the standard regimens, and then the only real consideration is this genotype 3 cirrhosis group. And really, I only do genotyping if cirrhosis is present. So if there's no cirrhosis, you don't even need the genotype. Any questions about this? This is it's a sort of a subtlety of Hep C treatment that I would say the most common mistake that I see even among very experienced Hep C treaters is they forget about this. They just say for whatever reason, they like the 1 pill a day and they give Sofvel to people with genotype 3 cirrhosis. They give Epclusa, they don't respond, and then that's the group that doesn't respond to retreatment, and then you're into this trouble where we don't have a lot of options left. So you're not going to see this very often. So if you found it confusing, don't worry about that. This is not that common.
Do they always get a genotype when they've got a test result, an RNA test result?
Yeah, so usually the genotype will come back with an RNA test result once it's sent for the first time. So you're usually going to know if they have a genotype, but you can basically ignore the genotype if they don't have cirrhosis. It's not relevant.
So if they have cirrhosis and you have a G3, then the alarm bells go off. If they don't have G3, you can pretty much go ahead.
Exactly.
Okay.
Yeah. And if they have genotype 3 and cirrhosis, and you don't remember, just try to remember genotype 3 cirrhosis is the one group to remember, and then you can pull up these slides and look at them again, or shoot us an email, and we can help you navigate that, because the resistance testing and all that stuff, I realize that's not routine to do.
Right.
So what other blood tests do you want to do? So whether or not you need to do a full workup for all other causes of liver disease, to be honest, we don't do this much anymore. Pretty much only do this in people where the ALT doesn't normalize after their Hep C treatment. So we just get on and treat the Hep C, and if it doesn't normalize, then we worry about it. But you do need to worry about a couple other things. One is renal function. So these drugs are safe in people with kidney disease, including glecaprevir, probenecvir, or Mavorite can even be used in people on dialysis. Not very common, but you should check their renal function. And then we really do want to check for co-infections, hepatitis B. And I'm going to show this in a little more detail. You won't see this a lot, But you will see people, most people do not have current Hep B infection, and that would be indicated by being hepatitis B surface antigen positive. But you will find a lot of people who acquired Hep B through injection drug use will have had exposure to Hep B, and they will be anti-core antibody, so hepatitis B core antibody positive, but surface antigen negative. This is reasonably common, becoming less common now that vaccination is more widespread for Hep B, but we still see this in almost 50% of people who acquired Hep C through injection drug use. So, and I'll show you how to manage this in a minute. HIV is really mostly just an importance of thinking about how to use the, is about drug interactions. So it's just a good opportunity to diagnose HIV and get them connected to care. I'm going to skip over this. So the on-treatment monitoring, Mia mentioned last time that in people without cirrhosis, no on-treatment monitoring is required unless you have concerns about adherence to the medication. So if they're taking their drugs, but really almost nothing needs to be done. And you just want to check for Hep C RNA 3 months after the last dose to confirm that they're cured. And because they don't have cirrhosis, they don't need any post-treatment monitoring for their liver. But if they have ongoing injection drug use or other risk factors for exposure, you need to monitor them for reinfection. If they do have cirrhosis, so these are going to be people with compensated cirrhosis, they do need some blood testing during treatment. Not a lot, but anyone with cirrhosis can occasionally get into trouble, either from the treatment or from other things going on, alcohol use or other things. So it's important to check their liver test during treatment, CBC, their liver function, so the bilirubin, albumin, and INR, their kidney function, and then again, confirm that they've been cured after treatment. And then after treatment, there's really sort of two things to follow. One is the consequences of liver disease. So if they had cirrhosis, and it's really only an issue if they had cirrhosis, and remember that fibrosis assessment should be done based on pre-treatment blood tests. If you didn't do it, or someone else didn't do it, try to get the old pre-treatment blood test. And it's mainly about their liver cancer risk. I'm not really going to talk about mild purgatory or this idea that people who already have liver failure may or may not get better, because for the most part, you're not going to treat those people. And then the second issue after treatment is reinfection risk. And the main point here is that if someone has ongoing risk exposures, particularly injection drug use, or you're uncertain about it, is to recheck them. And you have to retest here with Hep C RNA. The antibody will stay positive for the rest of their lives, so you shouldn't check the antibody again. It does not protect them from reinfection, so it's unlike other viral infections. Maintenance, trying to get them into opiate agonist therapy, so methadone, buprenorphine, or whatever other harm reduction programs you have are really key. But with anyone who has ongoing risk exposures, the Hep C RNA should be tested every 6 to 12 months, even if, and I would err on the side of doing this a bit more frequently, even if you think they may not be using, because you want to diagnose reinfection when it occurs and retreat people. And there's two reasons for that. One is for their own health, but also if someone's recently been reinfected, you also want to treat them to prevent any spread to other people. So this sort of treatment is prevention strategy. And then you also want to sort of promote good liver health. We talked about that a little before this session, but about, making sure that you're watching for things like fatty liver. So really focusing on a healthy diet and limiting alcohol use, particularly in people who had advanced fibrosis before treatment. They should remain abstinent from alcohol after treatment. If you are treating, it's important that you communicate the information well. So you'll see that we often had this term sustained virological response. It's a bit of a holdover from older times. We now really know that we should be referring to this as cure. So just use the term Hep C is cured. Don't say cure in quotation marks or suppressed or some essentially cured or something else. Say cure, because it's really gone. It's not coming back. And then remember, it is important to try to, if you're communicating with other healthcare providers, they may not be as familiar with Hep C, so just try to remember to spell it out a bit if you're doing the treatment. And then remember, no reason to check the Hep C antibody. Again, it's going to stay positive forever. Now, the reason I'm just highlighting this study, it's a complicated figure, but I just want to show a couple of points about it, is that sometimes people sort of feel like they don't really trust the FIB4. They're like, I'd really like to have a fiber scan before I treat. And I want to show you that the FIB4 is actually a very good test. And it's a good test because it's been the best test to show who is at risk for developing liver cancer after their cure of Hep C. And so this is what they looked at in this study is following at people up to 10 years after their Hep C treatment. The black lines are people who were treated in our old interferon days. Red lines are people treated with the new drugs. And you can see that if people had cirrhosis and they had so you knew they had cirrhosis based on their clinical presentation, exam, etc., and they had a high FIB4 score, the threshold is 3.25. Here you can see that they had a pretty high risk of cancer. About 2 to 3% per year, and that risk didn't go down after Hep C treatment. So these people are all cured of their infection, but they have a stable incidence of cancer after treatment, and so they need surveillance. And even if their FIB4 score was low, less than 3.25, but they obviously had cirrhosis based on imaging or other reasons you were confident they had cirrhosis, that risk, the risk of cancer stays high enough. This blue line is where doing ultrasound for cancer surveillance is cost effective, and it stays at that threshold out to 10 years. So these people need basically lifelong ultrasound surveillance. If the FIB4 is above 3.25, but it wasn't obvious that they had cirrhosis, so looking at them, clinical exam, if you did an ultrasound, nothing suggested cirrhosis, you can see just having the FIB4 above 3.25, that risk of cancer stays right at that cost effectiveness threshold. So again, a good marker to just say this person needs ongoing HCC or cancer surveillance with ultrasound every 6 months after Hep C cure, and that risk doesn't go down for out to 10 years. But if the FIB4 score was low and they didn't have obvious cirrhosis, you can see that risk is almost zero. So this gives you confidence that you can say if someone's FIB4 score is low and on an exam they didn't obviously have cirrhosis and had no history of decompensation, that person, I can comfortably discharge them from care after their Hep C is cured, whereas these other groups with a FIB4 above 3.25 or anyone with clinical evidence of cirrhosis, they need to have ongoing surveillance. Hope that makes sense. So now the one thing I was going to go into slightly more detail is about Hep B Hep B co-infection and HIV co-infection. So when the DAAs came out, I think the FDA made a bit of a mountain out of a molehill with this, but the reason I'm highlighting it is it's actually on the bottle. So there's a black box warning about Hep B co-infection, which you might see, and it alarms people if they're not familiar with it. So I want to just highlight what is concerning about Hep B co-infection and what isn't. And I'm going to highlight it with these two cases. So this is a case, this is the first person, has Hep C genotype 1b and also has compensated cirrhosis. And it turns out on screening, they have Hep B surface antigen positivity. So this is a current chronic Hep B infection along with Hep C infection. And you see what happens is they got their Hep C treatment in red, the Hep C RNA went down really low, but unfortunately what happened is at the same time, their hepatitis B DNA in blue went up, and if you look in the graph below, at the same time that their Hep B DNA went super high, their ALT in red and their bilirubin in blue went super sky high, and this person went into liver failure. In contrast, this person was surface antigen negative, but core antibody positive. So they've had past hepatitis B infection, but not current hepatitis B infection. Now let's see what happened here. RNA goes down nicely. They also did actually have a slight rise in the HBV DNA during treatment if you measured it, but nothing happened. ALT, bilirubin, flat. So no real concern. And so these are just case examples to illustrate the point, but now there's actually some data on this using the Veterans Affairs in the US, which has a lot of patients. They looked at patients, and you can see that first off, being surface antigen positive is really rare. They found it was under 1% of people with Hep C, but being core antibody positive was very common. It was almost half of the people in a pretty big cohort, almost 18,000 people, and 45% of them had Hep B past exposure, and that's our experience too. It's a little lower than this, but not much lower. But what was good, the good thing is that there's a very different risk profile, and what I just showed you on those two single case examples was really borne out here as well. In people who were surface antigen positive, some of them did have reactivation, but in a very large cohort of people who were core antibody positive but surface antigen negative, nobody developed clinically significant reactivation. So very reassuring. And I'm gonna skip this over. So just my take on this is there is clearly some risk in people who are surface antigen positive. So everybody should be screened. And we just stress this point that you really should do Hep B screening prior to starting Hep C treatment. Very unlikely they're going to be surface antigen positive, but if they are positive, my tendency is to actually treat their Hep B at the same time as treating Hep C to prevent this. If you don't want to do that, you can follow them, but you need to follow them closely. If you do treat them throughout out to Hep C SVR, so out to cure, but then watch when you stop the Hep B treatment because they may have a withdrawal flare. In people who are surface antigen negative but anti-core antibody positive, unless they're getting some other kind of immunosuppression or something, the risk is really almost zero of having clinically significant reactivation. So the summary is if they're surface antigen positive, either treat or careful observation, and this is your choice. If they're just surface antigen negative and core antibody positive, the risk is very low. If you want to be extra careful, you could recheck their ALT on treatment and maybe repeat the surface antigen. It would become positive again if they reactivated, but the risk is very low. They don't need Hep B treatment. So the no treatment refers to no Hep B treatment, but they can have their Hep C treatment.
So,
if you do want to,
sorry. So can we get speaking on behalf of not having to do this myself, could we get away with just testing for the surface antigen status? That's the only Hep B test.
Yeah, if you wanted to keep, yeah, you could do that. I mean, it's not a bad idea to find out if they're core antibody positive and surface antibody positive, to just do the full panel, and if they're negative for all tests, then to vaccinate them.
Okay.
So that would be the reason, but yeah, if you want to be simple about it, you could just do a surface antigen test, and if it's negative, you could treat their Hep C. If you do find their surface antigen positive, again, this is unlikely. Probably it's time to reach out and ask us for some help. But if you did want to treat them, you can treat them with entecavir or tenofovir. Both of them are fine. And you should generally treat them until, so you generally start the treatment with the Hep C treatment. So start the Hep B treatment at the same time. You can send the other Hep B markers like hepatitis B DNA, but you don't have to wait for the result, and then treat through to the follow-up for Hep C cure, so SVR12, 3 months after the end of treatment, and then use these other tests to help guide stopping. But I would say unless you're comfortable, again, this is the scenario where you might want to reach out to get some assistance. HIV co-infection is actually easy. We use the same regimens as Hep C monoinfection, similar safety and efficacy. The only issue is drug interactions. And you can really, if you're working with an HIV provider, it's very possible to find an HIV regimen that works with one of the pangenotypic Hep C regimens, so it's rarely an issue. Here are some of the drug interactions with some of the HIV drugs. To be honest, there are newer HIV drugs which have fewer interactions. So unless you're using an old regimen, there's really no issue at all. So finally, I'm going to go through a couple of cases. So start with a very straightforward case, and we'll get slightly more challenging as we go. But before I do that, does anyone have any questions about anything I've said so far? Including, but not limited to, David.
Hey, I just had a question about fibrosis monitoring.
Yep.
One of my colleagues uses something called the NAFLD fibrosis score. I think it's also an MD Calc. Is
Yep.
that any better? Is it the same as far as detecting fibrosis?
Yeah, it's a good question. So the NAFLD fibrosis score, is that's the non-alcoholic fatty liver disease. That's what NAFLD stands for,
Yeah.
Fibrosis score. So it is a predictor of fibrosis in people with fatty liver, not so much with Hep C. Now, it probably would work in Hep C to some degree, but it takes into account things like the presence of diabetes, the blood sugar, and then it also does look at the platelets, the ALT, and the age. So it's not so different than the FIB4, but I would say, at least in the Hep C world, the FIB4 test is more validated. So there's more data showing that it's reliable. So I would probably err on the side of using FIB4 rather than the NAFLD fibrosis score.
Okay, and so a little off topic, but for the fatty liver, would you prefer one over the other?
Probably slightly prefer the FIB4 again. A little bit more. There's actually more data showing, even though in theory the NAFLD fibrosis score is supposed to be a bit more specific. When you compare them, the FIB4 score, the cutoffs are a little bit different than we use in Hep C. So for fatty liver, if the FIB4 is less than 1.3, then you can be confident that they don't have advanced fibrosis. Whereas in Hep C, we have a little higher threshold, as I showed you, that threshold of 3.25 means they don't have cirrhosis, and you can treat their Hep C. With fatty liver, if it's above 1.3 but less than 3.25, that's a group where you may want to send them on to get more additional testing because they may have more advanced fibrosis that needs more significant management than just weight loss, which is our current approach.
Okay, cool. Thank you.
Any other questions? Okay, so let's go to a case. So this is a 56-year-old man who is a long-term resident of a psychiatric facility, and he's found to be Hep C antibody positive on screening, has a remote history of heroin use, but he actually hasn't used it in decades. But he does have some comorbidities. He's got diabetes, hypertension, he's obese, and he's taking some medications for the diabetes and hypertension, as well as he's on olanzapine for schizoaffective disorder. So we get his blood tests, and he turns out that he's HCV RNA positive. And here are his original liver tests. Maybe people can do, if you have a computer handy, you can quickly calculate his FIB4 score. So just to remind you, I think I said he was 56. And those are his AST and ALT. You're going to tell me that you need his platelets. There are his platelets. So you could do either his APRI or his FIB4 score if people want to go and go through the exercise of calculating it just to see. Because then my question is going to be to the group, and you can answer in the chat or just speak up. Do we need anything else, an ultrasound, genotype, or any other blood tests? Does anyone else want to do any other tests here?
Hep B surface antigen test.
Good. Anything else? Okay, great. Rochelle, nice work. FIB4 score is 1.09. Okay, so this is a low FIB4 score. This would be below that 3.25 threshold. So in terms of other things, you could do a workup for other liver diseases, but you know what? Probably don't need to. I mean, his ALT is elevated, but you could also probably just wait until after his Hep C is cured. David mentioned Hep B testing, very important. Ideally, we check for HIV. He doesn't need an ultrasound because very clearly, as Rochelle pointed out here, he does not have cirrhosis. Okay, so this is a straightforward person, Hep C, no cirrhosis. Now we don't care about Hep C genotype. We don't care about ultrasound. We can go ahead and treat him. So we have person without cirrhosis. It turns out he's hepatitis B core antibody positive, but he's surface antigen negative. He's HIV negative, and he hasn't been treated before. They actually gave us the genotype. We know it, but it doesn't actually matter. So you could treat him with either of our standard regimens, glecaprevir, probenecvir, or Mavorite, 8 weeks, 3 tablets once a day. Remember, it has to be given with food, or sofosbuvir, velpatasvir, 12 weeks, once a day, 1 tablet a day. Anything else you want to know before we start treatment? Sorry, I just got I'll be back in 1 second. They're just knocking at my door, but I'm on call and I just got 1 second. I'll be back in a second.
Just one thing. I'm not sure that Jordan mentioned this, that he has a talk online every 2 weeks called Hep C Net. Did he mention that at the beginning? Okay.
I didn't hear him say that.
Sorry?
I'm just saying I didn't hear him mention that, but I heard there's echo that he sits in. Is that still running?
Yeah, Echo's still running, but the thing about Hep CNET that's nice is that it's you just join when you want to, and it's just for an hour once every 2 weeks. And if you have a case that you're concerned about, you can just bring it up at Hep CNET. So he's always available to you at least once every 2 weeks.
Excellent.
Yeah.
And how do you enroll in that?
You write to one of his admin assistants. I'll give you the link. And if you have a particular case that you want to bring up, because there might be 12 people on it, you can write her and say, I have a case I want to bring up. Can you make sure that he covers it this week? And she'll do that for you.
And if you're just interested in sitting in on learning about other cases, you can just attend, kind of
All
thing.
the better. Yes.
Okay.
So I'll send you a link to everybody at the end.
Thanks.
So did anyone have anything else you wanted to consider to help you choose between these regimens? Sorry, but that's for stepping away.
I have a question about the food. Is it that it gives them an upset stomach, or it doesn't work and they still have Hep C?
It helps with absorption of the drug. So it's actually important. Food's important.
Okay.
It's not just about tolerability. It doesn't actually have any effect on tolerability, but it affects absorption of the drug. So people should take, if you're using Mavorite, they should take it with food. So you need to make sure that people have good food security, that there's not going to be an issue with if they're not able to get food on a reliable daily basis. So the one other thing to remember when we're choosing these, most of the time we're just asking people what they prefer, but always remember to think about drug interactions as well. So in this case, the person is taking a proton pump inhibitor, which a lot of people are taking, often for no particular reason. But remember that the PPIs, so the acid suppression, does have an interaction with Epclusa, with sofosbuvir velpatasvir. It lowers the absorption of the drug. So it's not a contraindication. You can use them together. And if you do want to use them together, like if the person preferred taking sofosbuvir velpatasvir, you can either ask them to stop the PPI for the first month of treatment when the viral load is particularly high and lower drug levels are a bit more relevant, or just take them at the same time is the preferred way to manage it, because then the acid levels are highest at the time that they're taking their drug, which helps with absorption. Or alternatively, you could just use the other regimen, glecaprevir, probenecvir. So it really is that easy, but let's go to a slightly more challenging case. So a 43-year-old man on long-term methadone. He's still using intermittently, but he hasn't been using very much in the past 3 years. He lives with his common law partner. He smokes. He used to drink very heavily and had a couple of DUIs. He's now what he describes as a social drinker. And he has a past medical history of obesity, depression, with a past suicide attempt. He's taking lansoprazole, so a proton pump inhibitor again, and quetiapine to help with sleep. So do his workup. We get his liver tests and his CBC. Can anyone calculate his FIB4 quickly, or APRI? Okay, I'm going to do it for you here, but these are online calculators, so pretty straightforward to do. And his FIB4 score is quite high. His APRI score is also high. Okay, so these would be an APRI score above 2 or a FIB4 above 3.25. And don't worry about remembering the thresholds. They're on the MD Calc when you do the calculation. So does he need a FibroScan? Who wants a FibroScan? So it would be nice, but he doesn't really need it. He's clearly got cirrhosis, and the tip-offs here are that the platelet count is low, the AST is higher than the ALT, and that's what's driving the FIB4 and the APRI score to be high. So in both of these, this is well above that 3.25 threshold, so you're confident that he has cirrhosis. The only value of a FibroScan, if you have it, it's nice, because it helps you figure out whether or not he's likely to have clinically significant varices and needs a gastroscopy. So he was seen in a place where they had it. His FibroScan was 18, and this would be a group who doesn't. So then you could take him out of that group, that he doesn't need an endoscopy. As I showed you before, if the FibroScan is less than 20, it's pretty unlikely that they have clinically significant portal hypertension. So you could save getting a gastroscopy, which is important because sometimes it's not easily available. So you could just go on and treat the Hep C. So additional labs. So his HCV RNA is 6 logs. So is genotype required? Richard, I see you talking. I don't know if you're you're muted. I don't know if you're talking to us or someone else, maybe not to us.
No, I'm mumbling to myself. I don't think it's required, but when we send it off to public health, they're going to do it anyways.
So they're going to do it anyways, but this is the time where I would say it's useful because he does have cirrhosis. Okay, so this is where it is useful. And this is the thing that I went on and on about genotype 3 and cirrhosis, because it turns out he does have genotype 3. And this is not so uncommon. So it's at least 25% of people who acquired Hep C through injection drug use will have genotype 3 infection. Now we do his other testing, his Hep B testing. He's also core antibody positive and surface antibody positive, but surface antigen negative. So if you wanted to be, so he doesn't need vaccination or anything. And we can basically ignore the Hep B. He's HIV negative. Does he need an ultrasound? So this is where we would say, yes, we would like to get an ultrasound because he does have cirrhosis, remember? So in anyone with cirrhosis, the ultrasound is not to diagnose cirrhosis, but it's to rule out liver cancer prior to treating the Hep C. So it would be helpful to get an ultrasound here. And so now we have someone who's got genotype 3, he's never been treated before, and he's got compensated cirrhosis. So we went through that he didn't have ascites, didn't have encephalopathy, and we went through those other blood tests and everything was compensated. So we've got our choices of using Epclusa for 12 weeks or 24 weeks, or adding ribavirin with 12 weeks of treatment, or using Mavorite for 8 or 12 weeks, or you need more information. There's more than one right answer here.
I just can't remember. I didn't take good enough notes, but I'm thinking the G3 is the one we have to worry about. So whatever we had to do for that one, I think it's the GLE/PIB that we use.
Yeah, so here would be a good option to use Mavorite or glecaprevir probenecvir, so is for 8 weeks, because he has compensated cirrhosis, so there's no problem with using the glecaprevir as the problem part of this regimen. It's the protease inhibitor part. But he could safely use it because he's got well compensated cirrhosis. And if you use that rule I mentioned before, his albumin was 38 or above and his platelets were 110, so just below the 130 cutoff that I mentioned. So that's the very conservative approach that you would, but if you wanted to say, well, okay, I'm a little nervous about using it, I still think you could use it. Then this is where you get into this question of with genotype 3 and cirrhosis, either adding ribavirin, but really you only want to do that if the person has resistance. So this is adding one extra layer of challenge here to get the resistance testing done. And again, this is somewhere where you might sort of, shoot us a quick email and say, okay, I've got genotype 3 cirrhosis. I remember you went on about that. Just want to make sure about the strategy that we're going to use, and we can help you navigate that.
I have just a question about Hep C RNA levels.
Yeah.
Just as a generalist, I don't do a ton of those tests. I don't have a ton of positive Hep C patients yet. So when it comes back, if it's negative, does it just say negative, or do you get some low level, or when do you worry, or tell me more about?
Sure. No, that's a good question. So if it's negative, if it's undetectable in the blood, then it will come back. Usually it will say negative. Now,
Okay.
Very occasionally you will get something where it says that it's below the limit of quantification. So it's less than, like it's at a very low level that it's so low that they can't give a number to it, but they can say that they detect something. We still consider that negative. So if it says less than, it's usually less than 15. Then if it's less than 15 or negative, it's negative. And
Okay.
any other thing you'll get a number. And it really doesn't matter how high the number is. The only thing to remember is that when you're looking at the number, it's the exponent value that matters. So like so this is 1.7 times 10 to the 6th, so it's 1.7 million. And that is a much higher number than, for example, 9.3, this number would be bigger, times 10 to the 3. Right, which would be 9.3 times 1,000, so 9,300. This is 1.7 million. So it's just focusing on this number. If you don't, you'll often hear us just say like this is 6 logs or 3 logs and we're referring to the exponent rather than to the first number. Does that make sense?
But none of it matters.
None of it really matters. It's just positive or negative, really. It's all that matters.
Okay, thanks. That's what I wanted to hear.
Yeah.
Or if it's less than 15, it's negative, and any number that's positive is positive. That's all you need to know.
I think the previous presenter mentioned something about a really low level where you kind of give them a chance to clear on their own. Is that?
Well, yeah, in someone with a new infection, with acute infection, if they have a recent exposure, if the virus level is very low, generally we still just treat them. But if someone's got a level, I mean, there's no exact threshold, but they can spontaneously clear during the first 6 months of infection. So if they have a very low level of virus, they're more likely to go on to clear. But we generally would still recommend treating most of those people right away, mostly to prevent the risk of transmission, especially now that the drugs are so well tolerated.
Thank you. That's great.
So now the other things that we're going to think about, so we've got both. So you could use either option here, genotype 3 cirrhosis, that if he doesn't have resistance, if you did this, then you could just use Sofvel alone for 12 weeks. If he does have resistance, you would add ribavirin, or alternatively, I would be very comfortable just using glecaprevir, probenecvir, or Mavorite for 8 weeks here. And then we just have to look at drug interactions. And so remember, he was taking quetiapine. So this is just showing you one of the drug interaction modules. Mia showed, I think, 4 of them last time, and any of them are fine. This is the University of Liverpool one. If you Google Hep C drug interactions, this is the one that comes up first. It's the one that I typically use, even though our hospital has its own. I actually like this one better, but this is just to show you what it looks like. So you tick off the drug you want to look at. So you can actually tick off both of the Hep C regimens. So sofosbuvir, velpatasvir. Now you do have to use the generic name. So you'll notice that throughout the presentation, I have always shown Sofvel or sofosbuvir, velpatasvir, glecaprevir, probenecvir. If you type in Mavorite or Epclusa, it won't find it. But if you use that, you can tick off sofosbuvir, velpatasvir. And if you could scroll up here, you would also find glecaprevir, probenecvir is also there. And you can see that both of them were ticked off. And then we put in quetiapine. You start typing it. It will give you the suggestion. And then you click it and it will give you the drug interactions. And so you can see with sofosbuvir, velpatasvir, no interaction is expected. So you get a green light. Whereas with glecaprevir, probenecvir, Mavorite, you get a yellow or orange light. If it's a red light, it's a contraindication. You really shouldn't use it. If it's a yellow light, you can click on this to get more information about it, and it will tell you what is the interaction. And in this case, it makes the quetiapine levels go up a little bit. So you could just consider lowering the dose of quetiapine. It's probably fine to use this. It's a manageable drug interaction, but some of them are more significant. And again, if you're not sure about this, this is something where you could ask. You could shoot us an email and say, this is the drug interaction, what do you think? But it sometimes helps guide your therapy. So what happened? So this person opted for sofosbuvir, velpatasvir. Now because of this drug interaction, so the provider was concerned about the drug interaction, so they went with this option of sofosbuvir, velpatasvir, Epclusa. Now he did have resistance testing done. He didn't have resistance, which was good. So then he just was treated for 12 weeks without ribavirin and fortunately was cured. So do we need anything else for this man? This man, he's just been cured of his Hep C. He's got compensated cirrhosis. So now that he's cured, anything else that people want to talk to him about?
We do annual ultrasounds and ELTs.
Good. So he needs ultrasound really every 6 months, not just annual, because the risk for generally cancer screening is with an ultrasound every 6 months. The reason for that is mostly based on the doubling time. It takes about 6 months for a cancer to go from being invisible to getting to the point where it might be at risk of not being curable. So that's why we generally do it every 6 months, but at least once a year for ultrasound. That's the most important thing because he has cirrhosis. Anything else? So just a couple of other good housekeeping things that you may want to do in this man. So the HCC surveillance or cancer surveillance is the most important. So he needs an ultrasound every 6 months. But he was, in quote, socially drinking. So this is someone with cirrhosis. They really shouldn't be drinking at all. So talk to him about alcohol cessation and ideally get him to none. We do have a harm reduction approach for it, like for everything. So less is more, but none is better than any in people with cirrhosis. He was still occasionally using drugs. So doing hep C RNA, and remember antibody not helpful here, RNA has to be done. I would do it annually in someone who is still periodically using. Even if they're in a methadone program. And then importantly, some other just generally good health issues. Smoking really increases the risk of liver cancer in people with hep C cirrhosis. So talk to him about smoking cessation, obviously other benefits to it, but even just thinking about the hep C in his liver. And then remember to always think about asking about partners and friends, particularly injecting partners, so that we try to reduce the risk that he gets reinfected, is trying to get them connected to care.
Jordan, I have a quick question. Why do you have to wait for treatment for the ultrasound on his liver? Like if you think you're only going to see, if you have a hard time getting this person in.
Yeah, so if you have a really hard time, you don't have to wait. But the reason is that if they do have a liver cancer, that's going to trump your treatment of their hep C.
Okay. Right,
so you need to manage the cancer first. And it's not like, people say like, well, really, are they likely to have a liver cancer? Well, the reason they might is because they're, often that person's had the infection for decades by the time they get to cirrhosis and cancer. Often the fact that they're presenting to medical attention, something's happened. And it may just be that they're a little more tired, they feel a little worse, they're seeing somebody who tests them. Now, it may just be that they have a more astute care provider who does the hep C testing, but it also may be that they had some subtle symptoms, which may be because of a cancer. Like, we're surprised at how frequently in people with cirrhosis, it's not common, but it's not 1 in a million that we find a cancer on a first screening ultrasound in someone with cirrhosis. So I would say it's definitely good to get the ultrasound before treatment if you can, but I would take your point that if it's going to be, you've sent the person for an ultrasound, they've missed 3 appointments, just get the hep C treatment done. That's still going to be the most important thing for their long-term liver health, more than the cancer surveillance, but it is good to get it done before if you can.
Because you usually don't see liver cancer on the first presentation with cirrhosis. It's quite possible, but it's not like the typical thing you see.
Yeah. It's not exactly. Yeah. That's a good description. So to summarize, treatment is much easier than it used to be. Simple regimens, few contraindications, minimal monitoring. We can give you support through the ECHO program, the ECHO Liver program, which is a free program. It's Mondays from 12 to 1:30, sponsored by the ministry. You get, if it's relevant, you do get CME credits for it. We also do preceptorships here, and either virtually or in person. And it's really great if you can provide hep C treatment in community. People prefer getting it from local healthcare providers. They don't like seeing specialists. It's hard to travel. This has been done incredibly effective with HIV, and I would really encourage you, if you're not already doing it, to get into hep C treatment. And I'll just reassure you that if you found today confusing at all, we can really support you on the first, at any point, but particularly for the first few people you treat. We've treated a lot of primary care providers, nurses, NPs, doctors to treat hep C, and often they will email us with the first couple of people, say like, this is what I was thinking, or not even this is what I was thinking, this is what I found, what should I do? We'll give them some guidance, and then usually after 2 or 3 people, they start to get pretty comfortable, and maybe I get an email another 2 years later and they say, oh, I've got a complicated case now, but I've treated lots of people in the interim, and they're very effective at doing it. So treating hep C is pretty pretty easy, and I would really stress that it can be very rewarding. It's much easier to cure than many of the other challenges that people are struggling with, things like addiction, which is very hard to manage. Hep C can often be a gateway to getting other medical care. So you get their Hep C treated, people realize that you're taking their healthcare seriously. They may take their healthcare seriously and work on addiction, other challenges that they may be struggling with. And just to highlight the real key elements today, that fibrosis assessment is critical. But even if someone has compensated cirrhosis, you can manage it. Just don't miss decompensation. So really ask about it and look for it. Then check drug interactions, check for Hep B and HIV, but that's about it. It's very easy to treat. And like I said, we're available and happy to help at any time. So I'm going to stop and happy to take any further questions that people might have.
Jordan, I just want to remind people in your presence about Hep C Net, just to make sure that it's an actual thing and that I didn't make it up in sleep.
Yeah, so I mentioned ECHO, which is funded by the Ministry of Health, and that's these sessions. It's ECHO Liver, so it covers more than just Hep C. So we talk about fatty liver, Hep B, alcohol, post-discharge management for someone that comes in and with decompensated cirrhosis. Some of the stuff I did today, we review those, and those are generally about a half-hour, 40-minute presentation followed by case presentations. People bring cases and we discuss them. And then we also have a program called Hep C Net, which is also funded by the ministry. This is to support what are called the Hep C teams. There are teams around the province that have a mandate to treat hepatitis C, particularly in more marginalized populations, particularly people who use or inject drugs. For example, there's a Hep C team in Sioux Lookout that Jagger's team is very familiar with, and some of you may have interacted with some of the other Hep C teams. We support the Hep C teams with Hep C Net, which is a session. It's typically 1 to 2 p.m. Eastern time on Thursdays. And we go through cases, sometimes a short didactic about updates, but most of the people there have treated some Hep C. Some of them are very experienced. Some of the people are new to it. And if anyone wants to join those, you're certainly welcome to as you start getting into treatment. And people ask all kinds of questions, from straightforward stuff. I got these test results back. I'm not sure what to do. You mentioned resistance testing. Tell me about that. I don't know what to do. I got the genotype back. What does it mean? Anything? Or I'm treating this person. They stopped taking their pills halfway through. What do I do now? All kinds of stuff that comes up, the sort of real realities of real life treatment. And we kind of work through those as a group.
Good. So Hep C Net is very focused on hepatitis C. Liver Echo is a little more general.
Yeah. That's a good distinction between the two.
Yep.
And even though technically Hep C Net is for the Hep C teams, happy to, if anybody wants to join those sessions, just let me know and we can send you the links. So we will send out a recording from today's session to everyone that joined. And with that, you'll have a copy of the slides. If it's not, I don't know that it's in the presentation, but I'll be copied on that email. So you can email me, Mia as well, if you have questions. And thanks for your note, Kaylee. I would say, even if you're not a prescriber, this is hopefully useful information for the people you work with who are prescribers. Because it is, and it's also, I think, really important for people who are not prescribers. You still may be interacting with the people who are getting treatment, with the clients, and trying to explain, having some awareness on your side of what are the things that are concerns, and trying to reassure them about how easy and effective treatment can be really impactful. So still a really important role to play, even if you're not writing the prescription, and also supporting people through treatment if they start. Today I'm going to talk about a little more complex hepatitis C.